So the neck and the lower lumbar spine, especially the lower parts of the lumbar spine, the lower parts of the cervical spine, they get affected badly because of these problems, what I'm telling you right now. And once the injury happens, it's a vicious cycle. So injury happens, again, the disc comes out a little bit, it starts irritating the nerve. So now, if you ask me, how to come out of it is reverse the whole thing, isn't it? See, we are always slouching like this in front of the laptop or in front of anything. So when you slouch, what's happening is you can yourself understand.
That's your neurosurgeon's recommendation.
Yeah, no, especially people who have back issues, avoid a chair with wheels. So there's a blood flow gets blocked. So due to a stenosis, we talked about stenosis, right? So if there's a blockage in that also is a stroke. That's called a CVT, cerebral venous thrombosis. So vein also that also is a stroke.
Alright, hey, welcome to this episode of DoctoPod. For those of you who've been following us for all these episodes, thank you very much for staying connected. And for those who are new, be sure to check out our other videos, and but not before you watch this one. Alright, so welcome back, and we have Dr. Krishna Chaitanya again with us. And Doctor, how are you doing today?
I'm good. I guess we need inputs from you all who have been watching our episodes. If it is becoming tedious and boring, please do tell us.
Please let us know. Yeah, of course. I mean, it will hurt us a little bit. There's a lot of work that goes into it, but I mean, it is what it is, right? So we got to know what works for you, what doesn't work for you. If I'm talking too much, that's also, please let us know. That's absolutely okay. We'll try and figure something out. In the last few episodes, we've been talking about general health, how we take care of ourselves and things like that. So carrying on from that without too much of an introduction, let's perhaps talk about the spine disorders that we have these days, things like herniated discs and narrowing of the spine and canal. Yeah, so the narrowing of the canal and these kind of things. And then we'll come to Bangalore roads and stuff like that as well. But let's start with herniated discs.
So, I mean, do you want evolution of the whole disorders, or I just want to have factual information of that?
Evolution of now that I'm intrigued now. Let's go with the evolution part.
Basically, I mean, for that you need to again here. Please, I don't want to bore you guys, but then see, we are bipedal beings, right? Bipedal means we walk into bipedal.
2 feet.
And we are mammals. We know that we are mammals. So the other mammals who are there, who are bipedal, say apart from us, say
bear, perhaps.
Bear occasionally is bipedal.
Okay.
Otherwise, our apes,
our cousins, yeah.
So chimpanzees occasionally walk. Even monkeys do walk. Primates do walk, and gorillas, they also do sometimes walk bipedal. But then predominantly, we are the only ones who are bipedal. So now what's happening when we are bipedal? So the spine, which was in all the mammals, it was like this. Okay, it was horizontal because they're all quadrupedal. Okay, yeah. So all the limbs are actually what we call on the ground, right? And then the spine was horizontal. Yeah. Okay, now due to bipedalism, what has happened is the upper limbs had to do some foraging work, reaching out, things like that. Yeah. So because of the foraging, we stopped using our upper limbs to move, and only started using our hind limbs to move. Yeah. So in that context, what happened is the spine, which was horizontal, which became vertical. Right. So when a spine which was horizontal became vertical, so what eventually will happen? The gravity starts acting over it.
Yes. Yeah.
Okay. So now initially the spine which is there, and spine, as you know, that it has multiple segmental anatomy. So there's one bone and you have a disc. Okay. Then you have another bone and another disc. So this particular architecture is important in mammals, not just in mammals, even also in other vertebrate animals. Vertebrate animals, any animal which has a spinal cord, or a vertebral column. So right from fishes, there are some sets of fishes, to reptiles, to birds, to us, mammals, and us, apes. All these have this thing. So basically, spine connects our brain to our limbs and our other body. So eventually what you can talk about is spine basically is an extension of your brain in order to facilitate movement towards a particular desirable object. It could be food, it could be a mate or whatever. So that was the reason why the spine had developed, for the reason that vertebrates developed a more complex brain, complex central nervous system, and to send the signals of central nervous system to the rest of the body, it needed appendages. So the appendages were obviously hind limbs and forelimbs, and then so eventually the signaling which was coming from the brain was getting passed through the vertebral column, through the spine. So in that you have two sides. One is the spinal cord, which is inside, which is a central nervous system. It's a part of the central nervous system, and then the covering of the spinal cord, which is made of bone and the discs, that is called the vertebral column. Okay, so we generally call spine, whatever you call spine, is basically it is together. Both you include spinal cord and also the vertebral column together. We call it a spine. So with this understanding that we had, from being quadrupedal, from being the spine being horizontal, it became vertical. So then when it became vertical, right, and then the spine itself, that is the bone and the disc itself, doesn't have any movement of its own. So it has to be governed by muscles which are attached to the spine, right? So we all are on the same page right now. So this much we are sure about.
Yeah.
So when we are erect, so what happens? The spine, the vertebral column is erect, and you have muscles behind it and to the side of it, which basically stiffen up so that undue stress doesn't act directly on the bone and the disc which is there. Right? Yeah. So I'll give a small example of that. When you have a crane which lifts heavy weights, like, so what do you have generally? You have a steel framework, right, which is the main bulk which holds the weight, and then you have a pulley which goes down and then it picks up, right? But then this particular pulley system, also at the top of that you have a a tension band which is connected to a very heavy weight behind. Right? Yeah. So that is basically a tension band. No, it's not to balance.
Oh, is it? Okay.
So what it does is basically the heavy weight, what it does is, whenever you are, for example, if you don't have that, so forget that heavy load which is there, along with the steel cables, forget that if it is not there. If you have only the steel framework and it is trying to lift up a heavy weight. So what happens is, now you get into your vectors, force vectors. So now your force vectoring, what happens is, now you're lifting a heavy weight. The heavy weight is another force, and then your force, when this is being lifted up, this vector tends to go
downwards.
The
pillar that is there, it'll...
The steel framework's force vector tends to go downwards because this is also here, and you're trying to lift it like this, so the force vectoring goes more downwards. So it'll offset out of the steel framework. So the vector starts to offset. If it is too heavy, then you start offsetting the the frame which is trying to lift it up, and then eventually, once it is too heavy, when the vector is out of it, it'll crack. The steel frame will crack at that point where it is very high force. So this steel cable, what it does is, it stiffens the steel framework. It makes it more tighter and resists the vector going down.
Okay.
That's why you have this force here.
And that is tied to something.
It is tied to a very heavy weight.
Yeah, further back.
Yeah, so that kind of resists the vector going front.
Correct. Yeah.
So in doing so, it will prevent the cracking of that.
Right.
So our muscles which are there around the spine are exactly like the tension band, that steel cables with that weight attached to that crane. Right? So what they do is they prevent the vector going forward. Right? So in doing so, whenever you're doing any weight or whatever, any lifting or of any heavy weight, it will prevent the vector going forward and prevent the injury to the disc or the bones.
Got it.
So now, with this understanding, you have to understand that in our present day, what are we doing? See, previously we were all, when we were bipedal and we started roaming around our forests, and even for that matter agriculture and all that, you're always physically active. Always the muscle used to engage and then try to force it, resist that forward vectoring. So in that sense, it used to prevent injury to the bone and the disc which is there, which is the vertebral column, right? But now, since we have got so, what do you call, non-physical, we're not at all, what do you call, doing physical activity, at all in the sense, literally. So, and we are sedentary. See, we are always slouching like this, in front of the laptop or in front of anything. So when you slouch, what's happening is you can yourself understand. When you slouch, you're behind the muscles which are there are not activated at all.
Correct.
So what's happening here is already, like, first thing is you're not letting the tension band hold it properly. So the vectoring is already going forward. So eventually what happens is there is injury to your the bone and the disc which is there. And obviously there will be only some set of areas it will happen. So the lowermost part here.
Yeah.
Because you will usually tend to bend on two areas. One is here and the other one is here. So the neck and the lower lumbar spine, especially the lower parts of the lumbar spine, the lower parts of the cervical spine, they get affected badly because of these problems, what I'm telling you right now. So now we can probably understand how the spinal degeneration happens. A herniated disc or a bulged disc is nothing but a injured disc because the between the two bones of the spine, you have the disc. Now, when you have, if the muscle is not acting on it and trying to resist the forward vector, which is always there whenever you are not active, okay, always, there is tendency to flex or a bend forward, okay. So, that when it is not there, definitely the injury happens, and once the injury happens, it's a vicious cycle, okay. So, injury happens, again, the disc comes out a little bit, it starts irritating the nerve, and because of the pain you further don't do much work, and and in this whole process, I think we discussed before, we use painkillers, try to reduce the pain, and in that process again we increase the injury happening there, and then this kind of continues and it develops into various problems. In one of that is a herniated disc, like that. So now, if you ask me how to come out of it, is you just reverse the whole thing, isn't it?
So you have to strengthen that.
You have to just reverse the whole thing. Strengthen the tension band, strengthen the muscles around the whole spine all along, and also avoid in your lifestyle, avoid situations where you have to continuously sit for a long time. Basically, sitting is not bad. Like what they say, sitting is a new smoking. It's not like that. Basically, continuous prolonged sitting is not good. So you get up, walk around, sitting straight, try to sit straight as much as possible, or recline and sit, so that the gravity is offsetted from the spine.
Okay, so sitting backwards is not.
When you're sitting backwards, see, when you're sitting back, you can see yourself that the upper body weight is now directly transmitted to the chair. Right? So it doesn't directly come onto the spine. But when you sit erect, again what's happening here is the muscles are activated. So what's happening is it is resisting the forward vectoring of the forces.
Right, but when you do this,
the muscle is completely not helping it, and this has been proven by experiments where they have taken cadaveric spine and then have put sensors in all the discs, and then they have seen different postures, which posture causes more pressures in the disc, and then they have found that slouching is the worst. When you slouch like this, that causes the maximum increase in the disc pressures.
Oh, I see.
Okay, so once it is more, definitely it will injure.
And then the other thing is that a lot of us tend to sit like this as well, because like we are looking at the screens and stuff.
So again, there what happens is that's not physiological for us. So this and especially in the context of not using the muscles properly.
Okay.
So I'll give another simple thing which we can do to avoid or prevent or delay this kind of a spinal degeneration is that do cardio. A simple brisk walk, a simple jog, half an hour a day. How is it useful? I'll tell you. See, what happens when you're erect? See, that's exactly our physiological stance, bipedal stance. When you're erect, completely chest up, neck up. So the whole complete spine musculature around the spine is holding it very properly. The tone is good, and when you're doing that act of jogging or walking rhythmically, one set of these muscles will keep contracting.
Okay.
So now like when you're putting a step forward, the other side muscle will get contracted. So this has to be mobile. So similarly, the rhythmic contractions of the muscle will happen, and that keeps the spine healthy, basically.
Okay.
So if you can inculcate one habit, if you can do half an hour of good brisk walk or a jog, that'll be enough. Probably a little bit of squats will help for the lower back. Otherwise, what will happen is you will develop pain, you'll develop discomfort, and your lifestyle and your daily regular activity will get affected. So if you don't keep it healthy.
So there were these like very simple steps that were given to us at workplace on ergonomics, which was basically that always keep the screen up to eye level. So the eye level should be at the top of the screen, and then always sit with like the knees, the hip and the elbows should be always at right angles. And so that's how basically you're supposed to set up your desk, is what they had said. Now that might not be very practical for a lot of
May not be practical, yeah, true.
They said it's the ideal way to do it.
Very true. I think one more very important thing which is still being followed is this revolving the chair with wheels. That's actually not good for the spine, if you ask me. Because what happens is a little bit of spine wants to be stable. It wants to keep the things as especially when you're sitting.
Okay.
When you're sitting, so what happens suddenly if you say move? So the wheels can easily freely move on either way or even front or back. So the spine may not be able to adapt that easily to these movements, because it also has to adjust its inner musculature and all that.
Mm-hmm.
So in that process, sometimes it can cause injuries to the disc. So I usually prefer to sit with a chair which doesn't have wheels, basically.
That's your neurosurgeon's recommendation. Try and sit on.
Yeah, no, especially people who have back issues, already they have developed back issues, avoid a chair with wheels, generally.
Okay. So what was this thing that you said the spinal canal kind of narrows?
So that's what. So as we were discussing about the injuries which happen due to lack of physical activity. So one is a direct injury due to the sudden increase in stress. For example, when you're lifting a heavy object, okay, which is you're not accustomed to lifting that object, and especially if you're not physically active also, like say you're occasional runner, or occasionally you go into the gym, and that's not, you should be a regular. So if you have not done that, then what happens is when you do that particular lifting, sudden vectoring goes forward, and then the disc completely opens up, and then it causes the disc prolapse into the canal. Okay, so that's an acute disc prolapse, it is called.
Okay.
So that causes acute compression of the nerves. So nerves basically they all travel in a canal called spinal canal.
Right.
Okay. Okay. So from the brain, the spinal cord, you need a space for the spinal cord to travel, right? So that canal is called spinal canal in general terms, common terms. So that because of the disc, it can get narrowed because now the disc suddenly came inside the canal and then narrows the canal, thereby compressing the nerve. Also, this narrowing can happen gradually over a period of time. So what I told you, the first example was acute, the sudden compromise in the spinal canal. The other set will be a gradually, slowly over a period of years together.
Okay.
Okay. So what happens generally is, say, a person has more or less a sedentary career, but then he doesn't do anything aggressive, like what the first fellow has done, like say lifting some heavy weights. But he is doing these things, but not appropriately doing physical activity. Then what happens is, there will be micro injuries happening in that area. Micro injuries. So because of the micro injuries, whenever there's a micro injury, the body tries to put in more tissue there.
Yeah.
Put in more, buttress it. So in the process of buttressing that area, what happens eventually, the space which is there for the nerve, that also gets buttressed.
Oh.
So because of that buttressing,
And starts compressing.
yeah, the nerve space for the nerve is not there anymore. And then gradually over a period of time, he will develop situation where there's no space, this because of that he'll have this pulling sensation in the legs or numbness or even weakness and stuff like that. So that's a chronic way also spine can develop issues, especially lifestyle can develop issues. Yeah.
So is it is now to avoid that, maybe one way to do it may be to slowly increase the resistance or the weights that you're picking up and stuff like that. Is that what you mean should be done?
Yeah. What we should do is you should at least inculcate in a week at least. I think there has been guidelines also for that 200 minutes, is it 2 hours, sorry, not 200 minutes, 2 hours, 2.5 hours of per week is the moderate activity, physical activity. So moderate activity. So that moderate activity means idea is that your heart rate should go up to one particular level. Say if you're 40 years of age, so your heart rate should at least reach 140. There's this thing, no, where 200 minus your age, that is 40, so it comes to 160. The 160 should be your peak heart rate. The peak heart rate means when you're doing extreme physical activity. As in we are doing intense like strength training and stuff, or running very fast. So you can hit 160 and stay there for 5 minutes or something, it will still be okay. Beyond that will be a little risky. So that's the idea behind this. It's a general guideline we have.
Correct.
So idea is that as they had given the guidelines, 2.5 hours of moderate activity. In that moderate activity, you should have at least some areas of intense activity also. So the idea of adding the intense activity is that your body should be capable of handling your routine activity and also a little bit more than that. Otherwise, what happens is always there will be situations where you need to, like say we just brought the chairs in from then. So situation like that where if you are not keeping your body fit enough to do these activities, then that micro injuries will happen inside and then they will start causing symptoms later on.
Got it. Okay.
So it's like when we store also like it, we usually store a little bit more than what we need. So I think that even the body also does. So muscles also need that.
Right. And a term came to mind. Is that what spinal stenosis is?
Yeah. So spinal stenosis is nothing but a narrowing of the spinal canal. Stenosis is a medical terminology for narrowing basically. So the stenosis can be anywhere. It can be in the spinal canal. It can be in the artery which supplies the heart. So the coronary stenosis. So that causes heart attack. It can be carotid artery stenosis. So that can cause a stroke. And the stenosis can be either a rapidly evolving stenosis or a slowly evolving stenosis basically.
Okay. And what other injuries have you come across with the spine of late?
These are the ones which we talk about as in general day-to-day activity, things like these injuries which are talked about. These two examples we talked about. But then other examples are where like we are traveling on the road.
Bangalore roads especially.
That is even trivial what do you call a pothole, and then you say traveling in a bus and it just jumps and then you fall after that and like you land on your seat again. But that itself can cause injuries, fractures in the vertebral column. The bone can get fractured, especially if the bone is weak. Osteopenia, osteoporosis we call, right? So because if that is there, then the bone can get fractured and that can cause injury. Similarly, even more severe injuries can happen, wherein what you call probably going very fast and if there is an accident, that can cause a very severe crushing of the spine as well. We have seen such injuries as well.
Okay. So what do you do in such cases? Like is it...
Depending on, basically there is a basic architecture of the vertebral column. So if the architecture is very much abnormally moved or because of the fracture and dislocation, we need to fix it with surgery. If it is not that much what you call dislocated or subluxated, then we manage it conservatively with some kind of a belts and bed rest and all that basically. Yeah.
I remember one of your colleagues had actually once written an article, or was it you? I'm not really sure. It was about these potholes and stuff like that. So, do you have like any tips on what can be done to handle it? Now, of course, we cannot expect much from the administration in any of our cities.
No, that's what. See, I mean, the most important thing when you have such bad roads is that whenever you anticipate such kind of a situation where you have potholes, you need to slow down. So slowing down itself immediately reduces because the minute you kind of glide through a pothole, the kind of what do you call you can call it just like a springy action which you get, no, especially if you're going in a bigger like a car or even this thing.
Okay. Tilts.
Recoil.
Yeah,
it's a recoil. So the kind of recoil it gets, it can really jump very heavy, and then you can land badly. And I have seen quite a lot of fractures like that, quite a lot, and not just elderly ladies. In fact, I've seen this happening even in youngsters also, because they don't have enough sun exposure and not enough vitamin D.
Right. So the reason that is said is vitamin D is essential for your body to absorb calcium.
Yeah, it's essential for us to keep our bones and muscles strong. Yeah. So that is, I think we have I can very confidently say that around 70 to 80% of urban population is vitamin D deficient. Okay. So I think that eventually somewhere or the other will affect us.
Yeah. But for people who have no other go, but to go take these roads and go through the pot.
Go slow.
So, go slow. Yeah. But other than that, is there anything else that you can think of that can be done? Like spine strengthening exercises, of course. I mean the back strengthening exercises.
Yeah, you need to do that so that as I told you before, the muscle is there to kind of alleviate the stress on the spine. Okay, it kind of redistributes the stress on the spine.
So is it because the muscles are softer, they have more elasticity to them, and that's why they get injured less compared to the bones? Is that how it is, or?
No, muscle also gets injured. Okay, only thing is the injury. One thing is basically the injury happens because anything is rigid, for that matter. For example, a rigid body gets deformed more obviously than another which is pliable. So you, like a balloon, for example, no matter what you do, it doesn't. Similar, you have a plastic box. You just do once, it just gets deformed. So in that sense, the muscle is not rigid structure. It can become rigid when you are doing a lot of activity. It can become rigid, but again, it's a mobile structure. So it kind of can take stress better than a rigid structure like a spine. Okay, so that is the reason why I'm still telling the muscle strengthening is much more important than trying to do anything else. So, yeah.
Taken. So now coming to the surgeries, you said that in many of these situations you go through. I mean, you have to go for surgery, no other go. Now there are different kinds of surgeries, right? Like one, definitely there is a the conventional surgery where you open things up and then you fix things down there and then you close them off. But there are also those surgeries that are minimally invasive, and then you have robotic surgeries. And in many situations, people might be given the option to opt for a robotic surgery, right? Or a minimally invasive surgery. What are the things we should keep in mind when we are faced with that kind of a choice?
Yeah. So, just like any field, like even surgical fields also, we have seen an evolution happening. And there are some sets of technology improvements which have really helped in improving the surgical outcomes. Okay, so now the whole idea of anything, surgery initially when surgery started, like evolved, the whole stress was on relieving the patient of his symptoms. Okay, so in that context, surgeons were not worried about the amount of, say, cut we need to do on the skin, or the amount of hospitalization or time required for him to be in bed post surgery. provided he's able to do his job that of taking care of the symptoms properly, he was not worried about that. So now surgery evolved from that, wherein now we are able to give the proper addressal of the symptoms. Now we are concentrated slowly on the reducing the morbidity of surgery. That means morbidity of surgery is that what the pain of surgery or the bigger the scar, the bigger scar obviously cause more problems. So that started, we started evolving into that, and the technology started helping us more into that. So we came to the place where now we are doing minimally invasive surgery or even other kind of surgeries which are there. So whole idea is that we try to reduce the discomfort to the patient, as in the scar, the surgical incision, and keep the symptoms optimum, like symptom free. The idea of surgery is first and the foremost is, one is, first do no harm. That is the first principle of surgery. Second is to cure the symptom. Third is to reduce the morbidity related to the axis. So we need to access the pathology to reduce the symptom, right? So now when you talk about minimally invasive and other things like laparoscopic surgery for abdominal surgeries, so they have reduced the the access related problems, basically. At the same time fixing the symptoms inside as well properly. Okay. In that context, you're talking about robotic surgery. So robotic surgery didn't really start off as a surgery to reduce the access related problems, that is the surgical scar related problems. Basically, robotic surgery came in because it started with abdominal surgeries and also pelvic surgeries. Okay. Why? Because when you do pelvic surgeries or a urologic surgeries that is related to the kidney and bladder, they're all very much deep inside our body. The pelvis is there, so it's deep inside. And when we were doing laparoscopic procedures, we had to use long, instruments to access that. So what happened was, they didn't have that much of degree of freedom. Okay. So for example, we have only, let's say we can move this way or we can move this way, our hands and our fingers. So robotic, arm had given us more degrees of freedom. So it could also move in different various angles. So because of the more degree of freedom, it was helping when robotic surgery came in. It helped a lot in the surgeries which are difficult for us to do laparoscopically or also open way, that is pelvic surgeries especially.
Okay.
To go to that, so access to reach the place. So that was difficult. So robotic surgeries came for that particular thing. Okay, because at the same time laparoscopy was there. So robotic came over it, and then it helped us to improve the access to that area and then to remove the tumor or whatever is there. Okay, but the outside skin scars are the same, just like laparoscopic surgery.
Correct, yeah.
So if you compare laparoscopic and robotic, there is no change in the surgical scar or the access related scars which are there. The same.
They are the same.
Only thing is, it is helping the surgeon to do a more tougher surgery in a easier way, because of the robotic arm having much more of movement all around.
So essentially, it is beneficial for the surgeons, not necessarily for the patients.
Yeah. So it makes the surgeon more comfortable, because normally if it is a laparoscopic surgery, he has to sit, he has to stand and do. So robotic surgery, the surgeon can sit on one side on a console, and then he can just direct the robotic arms to do in different angles. He can do it. So that is all it is. And obviously, so it is predominantly helpful for complicated surgeries where technical skill is more demanding, when the surgeon needs them. See, having said that, an expert surgeon was able to do even the more difficult pelvic surgeries and all were able to do it before. So now with robotic surgeries, you don't have to be really a great expert to do a difficult surgery. Even a more or less decent surgeon also can act and do that particular surgery with ease. So that is the idea of this technology.
Okay. Is it also fair to say that the chances of injury are slightly lower in terms of in case of robotic surgeries? You know, some accidental injuries that can happen while
No, it can happen even in robot, because eventually it is not that the robot is doing surgery. It is the surgeon himself doing the surgery, but lot of things are, like for example, surgeons usually will have fine tremors, especially when you are accessing, and because naturally, what do you call, we have inherent tremor in our body. So that becomes very obvious when we are operating at a great magnification. So robotic surgery, in that you will not have the tremor. The tremor will be gone.
Okay.
And then, as I told you, it gives you more degree of freedom. It gives you surgeon will be seated, so he'll be relaxed. So all these things will eventually lead to probably a better outcome. Okay, but it doesn't mean that in robotic surgery there is no chance of any injury or anything like that. If the surgeon is not careful, then definitely it can go wrong.
So if there is an option that is given, now how does it work with neurosurgery?
In neurosurgery right now, for the brain aspect of it, we don't have a robotic arm like that, because our working field is so small and narrow that our own fingers and our own things can't go in. So forget about having a robotic arm. But then in spine surgery, there are what we call, slowly it is coming up, especially when we use screws to fix the spine. So in order to plan the trajectory of fixation and all that, we have slowly robots are coming into the market where they are being used.
Okay. But then from the neurosurgery standpoint, you're saying with brain surgery, robots are not yet a thing. With spine surgeries, robots are a thing. They are starting, but they are not doing anything that a regular surgeon cannot.
Exactly.
So if there is a situation where somebody is put a question that, do you want to opt for a robotic surgery or a regular surgery, people can very easily go for a regular surgery as well, as long as the surgeon is.
Yeah, see, I shouldn't be saying this, but yeah, if the surgeon is very technically good and is experienced, I think if he himself is telling that you don't have to, I can handle it, I think he should confidently go, and because with all his confidence is telling you that he should probably accept it and get along with that procedure.
Cool. All right. Fair enough. Now coming to the youth, right? Are neurosurgical issues increasing with the youth? And let's not stick with just neurosurgery, but also neurology. Things like brain tumors and strokes, are they increasing with the youth? Like we keep hearing that, okay, oh, this guy had a stroke at 30, oh my goodness. And is that really, or did it used to be rare with 30-year-olds and 40-year-olds having a stroke?
See, I have been practicing neurosurgery for the past 15 years now. So in that I can recollect, yeah, definitely there has been a slight increase in the preponderance of strokes and brain tumors happening in the younger generation. Okay. Now I don't know before that how it was. More to it in the sense, it's eventually the genetic make of the person. So, and also because nowadays we are having such high-strung lives everywhere, and the inability, yeah.
A little bit about what do you mean by high-strung life?
High-strung life and high-stress life, basically.
High-stress life.
Yeah. Okay, so then if the body's ability is there to what you call tackle that and then live harmoniously and inside live healthily, then you'll not have these problems. But if it isn't, then definitely it will create an issue. Somewhere there is a problem. I think that previous experts are given an example of the same thing, right? About two cards or things like that. So yeah, so something like that. So yeah, so that's reason, definitely there is a increased preponderance happening. Yeah.
Okay. Do we have like different types of strokes, like, or are because strokes, I think these days have started, I mean they are used very loosely.
Yeah. So basically stroke, just like you say have heart attack, right? So what's happening here, heart attack or a stroke or a brain attack, the organ involved. So in a heart attack it's a heart, okay, or in brain it's brain attack it's brain. Organ's function is compromised. That's it.
Oh, that's a stroke.
That's it. So a brain's function is compromised. Now what's the brain's function? I'm able to talk right now. Suddenly I'll not be able to talk. Or if I'm able to use my hand, I'm not able to, so it's paralyzed. Or it could be even involuntary functions, like say our consciousness is there, or heart. All that also is brain functions, right? So those also can get affected. So all these composite things are basically just clubbed together to call stroke.
Okay, so stroke is an umbrella term.
Yeah, it is. It is. And then in stroke, so the function can get compromised in multiple ways. We just generally broadly classify into two ways. One is where the blood flow gets compromised. Okay. So there's a blood flow gets blocked. So due to a stenosis, we talked about stenosis, right? Stenosis could be suddenly a clot can just get from a heart or someplace, it just goes and lodges into the brain vessel, can cause stroke. Or sometimes the blood vessel itself is very weak and it kind of opens up, causing bleeding into the brain. Again, that causes loss of function. That also is a stroke. That's called hemorrhagic stroke. So the previous one is called ischemic stroke. Okay. Similarly, this blood flow going to the brain, similarly the blood flow going back from the brain also is there. So blood has to come back from the brain also. Correct. So if there's a blockage in that also is a stroke. That's called a CVT. It's called cerebral venous thrombosis or cortical venous thrombosis. So vein also that also is a stroke. Yeah. So just giving you different types. Yeah.
Now the symptoms for strokes, we know that the fast that we discussed in the previous episode, and we do have like treatment options. Again, you said that it's typically with respect to the blood flow. Fixing the blood flow will end up, and yeah. So, but now let's say that the lifestyle that leads to these risk factors. One, you said sedentary lifestyle or high-strung lifestyle that you just mentioned, but is there any like typical medical conditions that we can keep an eye out for? If I have this medical condition, I need to be prepared that I may have a stroke.
Yeah, there are specific, for example, some condition where hyperlipidemia. So where you have more fat flowing in your blood. Okay, so that potentially kind of increases the risk of the bad fatty acids getting lodged into the the blood vessels. So things like that, and then obviously diabetes and hypertension, definitely there is
those are like
those are usual suspects. So things like that, and then obviously there are some rarer ones also there. Vasculitis is there. So yeah, in general these two are the most important ones. Yeah.
Lifestyle, again, it's I think we discussed it
in fact, see, lifestyle itself, if you correct, there is a very high chance that even the diabetic and hypertension itself can be reversed for you, because most of the people whom we know all have insulin resistant diabetes. That is a type 2 diabetes. It's related to lifestyle, diet, and all those things.
Okay. Type 2 diabetes is itself called insulin resistant diabetes. Okay. That's basically that. Oh, okay. Now, this was a light bulb moment for me right now. It's basically, because you have insulin resistance, your insulin doesn't work, and therefore you have sugar in the blood. Okay. Anyway, this might be very obvious to you, right? Like, but regular people, like, yeah. Anyway, so brain tumors, another big topic. Typically, is that the chances of brain tumors have they also increased in youngsters these days, or?
Yeah, it definitely has. As in, I was telling you just a couple of minutes back about a coder who was just 34 years old, developed a very high grade lesion. Okay, and it's such an irony that he was just telling that mine is a very highly stressful work, and I had to sit hours together to do coding, and a small mistake I have to pick up, and now I'm not able to pick up those small mistakes. He was telling me that, within the last 2 weeks, I was not able to concentrate and not able to even find out the small mistakes which I used to do before. And when we did the scan, there was a huge tumor, and it was a grade 4 lesion, grade 4 tumor. So definitely in youngsters, it's seen more often. And if you ask me the reason for that, there are multiple reasons there, not just one. Obviously, the kind of genetic predisposition we all have. If it is see if the mutation, what happens is basically a tumor, a high grade tumor or whatever you call it, generally happens when our inherent genes, our genes go haywire, as in the genes which correct injuries. Like say, always there is especially in brain cells, I think we discussed in one of the first episodes that it needs glucose.
Yeah.
And glucose has to be metabolized to give ATP. ATP is the basic energy of the cell. So that happens in mitochondria.
Yeah.
And then in the process of this, churning out ATP, there is always an oxidative injury around the area, around the mitochondria. Because it's like say if you have a internal combustion engine and then it is continuously ramming, you're putting in fuel and it's ramming. So you will have the related to that, fuel getting combusted and all that, you'll have surrounding injury to the engine, right?
Correct.
Okay, the grease will get, the soot will get accumulated here and there, and it'll have wear and tear. So similarly, the oxidative stress is there also around the mitochondria. And also, it also, because the mitochondria and the nucleus is very close by, so even the nuclear genetic framework also gets affected because of this high oxidative stress.
Okay.
So now, if you're repairing enzymes or repairing DNAs, there are some enzymes called DNA ligase. Okay. So the repairing enzymes are not very good. So genetically, if you are not having a good DNA ligase enzymes, then whatever that highly intense mental activity was doing was creating so much of oxidative stress in his cells, is not being able to repair that. If the DNA ligase is not good, it will not be able to repair the injured genes there, and that itself is enough to trigger a cascade of bad things happening, like sudden multiplication of cells and tumor to form like that.
Okay, so this is why in one of our previous discussions you said antioxidants, if I remember it correctly, are like the engine oil.
Yeah.
Which help.
They reduce the oxidative stress. Yeah.
Okay.
Yeah.
Now, I know you said there could be multiple reasons. So please stop me where I'm wrong, but multiple reasons could be the food that we eat, the lifestyle that we have with respect to being sedentary and stuff like that, and of course the genetic makeup also that you said. There are foods that increase the oxidative stress in the body, or
Food doesn't increase oxidative stress. Basically, if you are eating food which is low in antioxidants or the chemicals which are helpful in reducing the oxidation, then it can cause. So that's the reason why we always talk about processed food or food which is like only carb food without fiber and without the greens, without the other colored food, colored vegetables and all that. If you don't have that in your diet, what happens is your diet is predominantly only carb, only fat, or only the protein.
yeah,
That will eventually lead to the lack of those antioxidant chemicals which help in reducing the oxidative stress. So having a balanced food where your main basic carb, protein, fat is taken care of, along with that the other things which are necessary to kind of make the whole thing smooth, the whole metabolism smooth, that is the vitamins, those have to be also been taken care of.
okay. Now that's something that we'll probably have to pick up with some a nutritionist or somebody who can tell us how exactly these things are doing, or would you be able to tell us?
Nutrition is like which particular food to eat or something like that?
Well, why or let's probably drop that. I guess that will just get into too many minutiae. And,
no, you can just tell what is it, like what exactly you're talking about.
I'm thinking in terms of the oxidative stress. We have to add antioxidants. Antioxidants are typically found in very highly colored vegetables like say red cabbage, beetroot. These have like a lot of these antioxidants.
Not just that, even lemon for that matter. Vitamin C is an antioxidant.
Vitamin C is an antioxidant.
So like that, yeah.
Okay.
Even vitamin A has antioxidant properties. Like
That's why they say
egg yellow has antioxidants because it has much of vitamin A in that. So like that, yeah.
Cool, and that's why they say that your there should be like at least 5 colors on your plate. or something like that. Yeah, I've heard this somewhere that at least you should have 5 colors on your plate, and white is not considered a color. So, right. Anyway, so brain tumors. How do you find, like, what typically are the symptoms for brain tumors?
I think if you ask me, like, give the same example, the guy who we did surgery recently. So they'll have headache. I mean, one of the most common is headache. So that gets kind of ignored. That kind of get ignored because anybody, I mean, who's having a job to do, or even for that matter, at home the kids are shouting or whatever. So headache is a very common symptom basically. So how do you actually detect that? Okay, is that headache serious enough to get it evaluated or not? Obviously. So when the headache is not coming down with even your medication, or even say good night's sleep, or say something like that, which will reduce a general headache. So that kind of headache you need to evaluate. Definitely you have to do it. Okay. Or a headache which is associated with vomiting. Okay. Needs to be evaluated. But having said that, usually a patient who has migraine is one of the most common headaches which we have. That also has an association of vomiting also with that.
I was about to ask that. Okay.
This headache not coming down with any routine painkillers or medication.
And it is chronic. You keep getting, or is migraine also chronic?
No, migraine usually does a tendency that triggers for migraine basically. Some kind of triggers. Sunlight is a trigger for migraine. Okay, so things like that. So some particular food items are triggers to migraine. So basically these are the things. Loud noise sometimes can trigger headaches. So, or even bright light. So if you don't have the trigger, then this headache is just happening, persistent. And then I think then you should evaluate it. That's one of the symptoms. And obviously, other than that is seizure. Seizure is one. So if the brain is irritated in one place, it sometimes can cause seizures. Apart from this, again, the things that function, loss of function, that is, vision loss, or he's not able to talk properly. Generally, that's what we see if you have a left-sided brain tumor or whatever. Slowly his verbal output starts coming down, and he'll not be able to comprehend what we are talking. He'll start repeating words. So that's when you should be suspicious about some problem inside. So like that.
There are different kinds of tumors, right? Like not all tumors. You said there are grades in tumors. So what are these grades?
So obviously we just, for our understanding and for also to treat the patient properly, we grade tumors based on its multiplicity, as in how slowly growing the tumor is, or how fastly growing the tumor is. Okay. So a grade 1 tumor is generally a very slow growing tumor. So that means to say that it grows to a significant proportion over years. Okay. So similarly, if you have a grade 2, it's a little bit of lesser than that. So it's a little more aggressive. Grade 3 and grade 4 are generally counted as more aggressive tumors, where they start growing very fast. Okay. So there is something called as, we have some indexes. So in our pathology, when we see the tumor cells, so we have some percentages. So if the tumor growth is less than 5% of the 100, in the sense, in 100 cells, if you see, if the growth is only 5% of tumor cells are actually dividing, okay, then we consider it as a slow growing tumor. Similarly, if the growth is, say, 20 to 25% of the cells are actually dividing, that means 100 cells, if the 25 cells are dividing, that means it's a very, very high growing tumor. So in that sense, we have different treatment modalities for both of them.
So how do you know how fast it is growing? Is it that you take one scan today and then...
Not a scan. We're talking about the one we take when you do surgery and remove the tumor bits.
Oh, okay.
And we analyze the tumor bits under a microscope. Okay. So when you see under a microscope, we'll see a cell, okay, and we can also see a cell which is dividing.
Okay. Like live, you can see that live?
No, not live, in the sense, once you cut the specimen out, so we have frozen that particular cells or tissues, whatever is happening, it is frozen now, right? And then immediately the multiple reagents are added to freeze the activity the way it is.
Oh, okay.
Okay, so that it will not get decayed,
Oh,
right?
okay.
So then when you take a thin slice of that tissue and then you see it under a microscope, we'll see, say now in that microscope we see 100 cells. And then in the 100 cells you will see that there are only 5 cells which are dividing. You can actually literally see them in this phase where it
Like
is.
an 8.
You can see, we have seen some videos where the cells divide.
Yeah.
So you can see, literally you can see that dividing cells. So when you see that kind of cells, then you say, okay, in 100 cells, the 5% of them are dividing. So that will tell us the rate of growth of the cell.
Okay, I see.
So that is one of the most important markers for grading a particular tumor. So in brain tumors, that's why we grade into 4 general tumors.
So any tumor you like, the moment you see a tumor, you just surgically remove it off, is it? Like regardless of how fast it is growing in the person.
Yeah, because even whenever a patient comes to us with a symptom, right?
Symptom. Oh, I see. Yes.
Whether it is slow growing or a fast growing,
Anyway, it has to be acted on.
yeah, see a slow growing tumor. That's the reason why a slow growing tumor comes to us after it has grown very significantly big. And that's when the symptoms start coming. Because the brain is trying to compensate for a slow growing tumor's growth, but to an extent, right?
Yeah.
Okay, beyond that you can't already compensate. So that's when they'll come to us.
In a 3 people sit, maximum 4 people can sit, not more.
Exactly.
But not all tumors are cancerous. So how do you?
As I said, what cancer again is, as I told you, it is cancer. When you say something is cancerous, we talk about 2 virtues of that. One is the spread and the speed. Okay. So if it is spreading, okay, and the speed with which it spreads is high, that is in grade 3 and 4, we generally term it as cancerous in brain. I'm talking about. Whereas apart from brain, where other places you have tumors that have a different set of definitions for cancer. But for in brain tumors, usually grade 3 and generally grade 4 are termed as cancers or cancerous.
Or malignant.
Malignant, yeah, malignant.
Now, I suppose we cannot or we can never prevent a brain tumor as such.
Yeah, it's not in our hands to we can't really go in and see what's happening in that cellular level, right? So not possible. Yeah.
So what are the treatment options that are available by, let's say that somebody is, so there is a brain tumor detected. Let's say somebody just went for some MRI and there is a tumor that you see there. What would you do? There are no symptoms being shown.
Good question. So basically what we do is we see the MRI. So we have some telltale signs of its aggression. Okay, so we can in MRI we can find out whether the tumor is appearing aggressive or it is probably a slow growing tumor. Okay, you can make out. So there are some sets of characteristics which we know. So based on that, we will obviously advise him. And since he has only found it incidentally, okay. So if there is an aggressive twist, angle to that tumor, we will definitely tell them to get it operated. Otherwise, we can always observe it for a couple of months and see if there's any change in the growths. But say after 3 months, we repeat an MRI scan and in that there is a tumor size increased, then we can confidently tell him that there is a tendency for this tumor to grow at this rate, so better get it removed. So like that.
Can tumors be anyway? So in an incidental detection scenario, are there medicines to control the growth of the tumor?
So when you want to give medicines for control the growth of tumor, you should understand the histology of the tumor. Histology means what is the actual cell type it is made of. Only then we'll be able to actually attack it with some particular treatment. Okay. So there is what you call role of medical management in tumors when you can understand what tumor it is. So in brain tumors, we do give medicines for pituitary tumor, especially for pituitary tumors, where you have the tumor developing in a pituitary gland. So in a pituitary gland tumors, what happens is based on the hormonal levels, there are some set of hormones which we generally evaluate. So based on the hormonal set, like say prolactin is one hormone. So if you have a very high prolactin level and you have a tumor, we can give medical management initially to see if it can shrink in size. Okay. But having said that, it's not again for all the patients who have a prolactin high prolactin and also a tumor. So if it is a very massive tumor, it starts compressing on the optic apparatus, the vision apparatus which is around it. So in that sense, medical management will not help. Then you have to go for surgery.
Okay. And is there something called as a brain biopsy? Can that be done like without?
Definitely, because lots of times we'll have very ambiguous lesions inside the brain, where it doesn't fit into, say, a tumor, or it doesn't. Sometimes you have other, as I told you, vasculitis, where there's kind of some
Inflammation of the blood vessel.
Vasculitis blood vessel. Similarly, sometimes you have inflammation of the brain as well. Okay, so there are some immune-related issues, diseases. Autoimmune diseases. So some multiple sclerosis is one, and all those. So these are all lesions where you have brain lesions. Okay, sometimes you have blood related, like lymphoma, also can affect the brain. So when you are not sure about what it is, that time it's very advisable to take a biopsy, so that we can get the histology. Then we can, based on that histology, we can treat it.
Okay. Is there a chance for a brain tumor to come back, like after it?
See, so the thing is here again, so removal. So what happens in brain is that, since, say, if you have a tumor, say, or on the skin, you can confidently remove a good chunk of normal skin, and then we can probably put a patch of skin from other place and then manage it. But in brain, you can't do that. You can't remove more brain than where the tumor is. So, because a lot of times you are having a tumor which is just adjacent to the place where we are talking, the brain where the talking starts, or where the movement starts happening. So, in that sense, what we tend to do is we do something called as a safe maximal resection.
Okay.
So, for us, what's the most important thing is that the function should not get affected.
Do no harm.
Yeah, so the function should not get affected. At the same time, we should be able to remove as much of tumor as possible safely, and then give the best result for the patient. So there are tumors where, if it is, say, I'll give you an example, right side frontal lobe, say this frontal lobe right side, generally speaking, it doesn't have much of personality changes. I mean, if you have a tumor there, you really can't make out, okay. So we can confidently go and probably remove even a little bit of brain also, and his lifestyle will not change much, right? But similarly, if we have, say, a left-sided lesion, tumor is there, and especially around the speech area, then if you try to remove the complete tumor, you may land up in injuring the speech area as well. So we have to balance. It's very important for us to balance out the improvement or the symptom improvement which you are giving him, to how much injury you are giving to the brain also, how much tumor you are removing also. So here the trickiest part in neurosurgery is, because lots of times, in my own case, it has happened a couple of times where I could not remove the full tumor because of the same fear of giving a functional deficit to the patient. We probably have removed it subtotally. We not removed it completely, but the symptoms get improved because the pressure is released and all that. Now, since we have other modes of treatment, because we can give radiation therapy, we can give chemotherapy if it is a high grade lesion, we can always offer that. Or other thing what we can do is, we can even go in again after a week or so, or even after a month or so, when the patient's condition is better. Even the brain's swelling and all comes down. So we can always do a second look surgery as well. But unfortunately, in the present trend we are in, if another doctor says, oh, we could have done it off in the first sitting. So it's easy for people to just get carried away by other doctors, consultants.
Definitely.
That's one problem which we have. The other problem what we have is that people don't have enough money to go for a second surgery.
Oh.
Say, in the West, they don't have a problem there. So they can always say, we'll do this much, and then later on, after a month or so, we'll again go in and take it out. But in India, still that concept has not sunk in, and somewhere there is a problem with economics as well, the money, finance as well, where the patients are unable to in the sense, whenever we say this, they'll again go for another second opinion, and the doctor says, no, we'll remove it completely. So this is what is the problem happening in India with us now. So the question was something else, and I just...
No. That it was. I mean, can we remove the? Is there a chance of the tumor?
So that is the reason why the concept in neurosurgery is the safe maximal removal of tumor, preserving the function as much as possible.
And so that also means that there is a small chance that the tumor comes back because something may have been left.
Yeah, so that is the reason why we have this another modality of treatment, the radiotherapy. So depending on aggressiveness of the tumor, see if it is a slow growing tumor, if you remove 90% of the tumor and 10% is still there, that's 10% will take 20 years to grow again.
Correct.
So you don't have to really worry about. But if there is a tumor which is going to grow in another 5-6 months, then you have to give RT. So with RT, you basically multiple high energy X-rays are focused onto that area, and then it fries that area completely. That's it.
I think with that, let's wind up this episode of DoctoPod. I know that it was quite a bit serious, this one, with some situations where we could typically feel helpless, but I think one thing, and tell us, doctor, how far the medical field has grown. Like, what all things that used to be a scary thing, say 20 years back, that's no longer a scary thing, or maybe in the beginning of your career, what all things were scary and they are no longer scary?
Yeah, so previously, maybe 20-30 years back, when anybody had a brain tumor, generally it was considered that situation is hopeless, patient is going to die. So that concept has changed now, pretty much it has changed. Brain tumor, brain surgery is not a end of life thing. It is very much the patient can lead a very normal life like anybody else. Okay, and even not just the reason of that improvement being in two things. One is the technology which is being utilized now. We have very high-end microscopes which help us see the even the minutest of the brain and the blood vessels and other things nicely, and also the instruments which we have. We also have something called as navigation, which helps us reduce the amount of skin which you cut to go in, and it helps us precisely where to go. It helps us to guide into the tumor where it is exactly. And also, most importantly, all that is there, but the most important thing is our surgical expertise also has improved a lot. So previously, we were all very rough. Now the surgical, the way we handle the tumor, the way we remove the way we handle the brain itself has improved a lot. Significantly, it has improved, and that has led to a very good improvement in the results now. So, as you rightly said, initially when we were starting to learn how to operate on the brain, we were all scared of, say, one particular surgery used to scare us. But now that if you do the surgery again and again, you'll lose the fear of that. Yeah. So, in spite of that also, still it's good that I do have that whenever I'm doing a surgery, I'm always not overconfident or confident that I can do it. Because always, as a dictum, surprises keep coming up. Okay. So, you need to be ready for the surprises. So, that's why I'm a firm believer of Murphy's Law. Whenever you don't expect anything, it will happen. So, keep that little, gray area when you're operating and don't get overconfident. That's it.
Yeah. No, but then I also know somebody who had a brain tumor resection happening 15-20 years back. And that person is leading a very, very normal life today. I just met them like 2 weeks back, and they seem like more normal than any other time. So, brain tumors are not necessarily always a bad.
Yeah, it is not. And brain has a very inherent capacity to do, we call it about neuroplasticity. So whatever little brain, if it is removed, so one of the functions of that particular brain is removed.
Yeah.
But their adjacent brain will easily try to compensate and adapt for the loss of function. So neuroplasticity is there, and it does really help.
Yeah, And today the diagnostics have also improved, right? Compared to like 15 years back, diagnostics have improved today, so it's easier to detect.
True, very true. Yeah.
So anyway, with that we'll end this episode, and the next one we'll talk about brain injuries. Not that it's very interesting. I mean, it is interesting. It's not that it's a good thing, but it's something that can happen, along with especially when it comes to comorbidities that people have. But we'll come to that in the next episode. For this one, if you like what you saw, go hit that like button, subscribe to us to get more of these episodes, and ensure to leave us a comment so we know what works for you, what doesn't. Until the next one, thank you and take care.